Um, okay, so today I'll be talking about transitions in pediatric care in narcolepsy to the adult medical system. But along the way, I wanted to highlight some important issues for pediatric patients, adolescent patients, as well as young adults. My disclosures, I've served on consulting boards for the following companies listed here, and I currently do have some research funding from Jazz Pharmaceuticals and Harmony Biosciences. And as Monica said, I'm on the medical advisory board for Wake Up Narcolepsy, as well as the Hypersomnia Foundation. So today I'll be reviewing the symptoms and comorbidities in pediatric narcolepsy, actually quite briefly, but just as an overview for anyone who might be newly diagnosed. I wanted to highlight sort of challenges in management of narcolepsy in the adolescent population, and then begin discussing sort of a roadmap for the transition process from pediatric to adult medical care for narcolepsy patients. I hope you gain some important resources on the transition process from this talk, as well as sort of we can identify some accommodations that can be helpful for children, adolescents, as well as adults to optimize functioning with narcolepsy diagnosis. So in terms of just starting with the diagnosis, this is actually how my research got started. And this was through funding actually from Wake Up Narcolepsy. And really it was looking at the problem of diagnostic delays. So if people are not familiar, narcolepsy, typically the onset of symptoms is somewhere between 10 and 20 years of age. And that's highlighted in this, this bar graph here, where the gray is representing the frequency of diagnoses. And you can see that the light gray is denoting that people oftentimes develop symptoms between 10 and 20 years, as stated. But the diagnosis is what's in black, and you can see that there's a decoupling between those light gray bar curves and the black, and that's really showing that oftentimes the diagnosis is not made until patients are in their adulthood. So that creates a delay of somewhere median reporting of 10 to 15 years when this study was first published. And so with Wake Up Narcolepsy's help, we used a survey that was going around to patients to collect additional information. And we asked them that simple question of how long it was taking to get a diagnosis of narcolepsy. And surprisingly, even though it was over 10 years between this first study and the second study, patients were still reporting that a third of them, it took more than 10 years. And of those patients who reported a delay, which we specified to be even a year or more, most of those patients were pediatric onset and symptoms. So if you are someone who developed symptoms before age 18, there was a doubling of that diagnostic delay risk. And if you didn't have cataplexy, there was a near doubling of that risk. And so that really highlighted the population of pediatric narcolepsy and the importance of educating providers on recognizing symptoms in a timely fashion. So to kind of help that bridge, we created the Pediatric Hypersomnolence Screening Tool with support from Wake Up Narcolepsy, Coveris Healthcare, and the American Academy of Sleep Medicine. And this was a survey that we developed in part with focus groups of patients, their parents, as well as their teachers, actually, to find out what symptoms of narcolepsy were observable to others or easily identifiable in those early years, and trying to put that into a survey so that people could use that as a screening tool for identifying these patients. And so we identified 4 factors in the survey: sleepiness, cataplexy, REM-related phenomenon, and fatigue were all symptoms blocks that patients reported, not just in narcolepsy, but also in idiopathic hypersomnia for some of these domains. And we validated the survey compared to standard multiple sleep latency testing, as well as other surveys. And we found that the survey actually performed really well for the diagnosis of narcolepsy or idiopathic hypersomnia. If people scored greater than 24, there was a sensitivity of about 81%. and a specificity of 81%. And we developed a subscore just for idiopathic hypersomnia with a focus of more on sleepiness and its functional problems. And that also had very good sensitivity of 89% and specificity of 71% for idiopathic hypersomnia, specifically compared to controls or other patients with sleep disorders. So if you're not familiar in terms of screening tools, this performs actually pretty well. It means that it captures about 80% of the people with symptoms of idiopathic hypersomnia or narcolepsy. And while it's not a diagnostic tool, meaning you can't use this alone, our hope is that this could be used in the community, in schools, primary care offices, to really focus on these patients who score highly and refer them more directly to sleep centers for diagnostic testing. So in terms of narcolepsy symptoms and comorbidities, I think this audience knows these symptoms very well, but just in case we have any new diagnoses patients, there are two forms of narcolepsy, type 1 and type 2. And functionally, the symptoms of narcolepsy are thought of as either a sleep-wake state imbalance. So people have almost 100% of people with narcolepsy will report daytime sleepiness. And that's because they have difficulty sustaining wake bouts without intrusions of sleep. And there's also disrupted nighttime sleep, which is reported in somewhere between 30 to 90% of patients, depending on what population you look at. And that's referring to that patients have difficulty sustaining sleep without intrusions of wake. So there's a problem of state maintenance, essentially. And more specifically, patients with narcolepsy have intrusions of REM sleep. And REM sleep is a unique sleep stage where we dream, we have an absence of muscle tone, except for our eye muscles and diaphragm. And for reasons we're still not sure, there's activation of these REM circuits into wake periods in narcolepsy patients, producing symptoms of cataplexy, sleep paralysis, and the hypnagogic or hypnagogic hallucinations, which are probably intrusions of that dreamlike imagery from REM into wake. There's been more focus in the last decade on the comorbidities in pediatric narcolepsy. It's been reported that somewhere between 25 and 60% of pediatric narcolepsy patients are obese. And oftentimes it's a lot of weight gain, 10 to 20 pounds at the first onset of symptoms. And we're still unclear as to what that might be, or if there might be some local hypothalamic changes that are occurring, contributing to those symptoms when people develop narcolepsy. Precocious puberty has been reported in anywhere from 16 to 40% of patients, and also might be related to some kind of hypothalamic network problem, but we still don't really have the understanding as to why this might occur. Obstructive sleep apnea might be related, in fact, to the obesity. As people put on weight, the risks of obstructive sleep apnea also increase, but that's been reported in 9 to 25% of patients. Periodic limb movements is this kind of constant twitching that occurs during nighttime sleep. Can be really disturbing to a bed partner, but oftentimes doesn't, we think, bother the patient too much. That's been reported in 36% of patients. And there's more and more recognition in the adult population of hypertension, and that might be related to medication use, such as stimulants. This has been understudied in the pediatric population. But interestingly, one paper showed that 41% of untreated patients, meaning that they weren't on stimulants or medications that could increase blood pressure, had a history or elevated blood pressure suggestive of hypertension. And of course, that number goes up on with people on stimulants, so it's up to 60%. There's a whole host of other comorbidities that I'm not going to go into in great detail, but GI symptoms is a common one that I see clinically with dysmotility or constipation symptoms, headaches, migraine, or chronic tension headaches, and under other endocrinopathies such as thyroid disorder. In terms of other comorbidities in the realm of behavior and psychiatric problems, patients oftentimes have ADHD. And this was sort of hotly debated whether that just might be a manifestation of the daytime sleepiness. But in one study, they showed that patients who had narcolepsy and were treated still had ADHD symptoms, suggesting that even though their treated sleepiness had improved, their ADHD symptoms stayed constant. And so we do consider that a comorbidity. You might have probably heard or experienced brain fog as a common issue with patients with narcolepsy, and certainly cognitive issues have been explored in the population. To the best of our knowledge, the literature doesn't show that there's problems with, say, true cognitive outcomes such as IQ or whatnot, but it seems to be a problem where sustained attention and possibly working memory are affected. There's a high reporting of mood disorders, depression, anxiety, and obsessive compulsive tendencies up to 25%. And more recently, there have even been reports of schizophrenia or frank psychosis in this population. And initially that was associated with autoantibodies that attack specific areas of the brain, including a condition called NMDA antibody encephalitis. But that's been followed with showings that this psychosis and schizophrenia occur even without those antibodies. And we're still unclear as to what might trigger that in some patients and not others. In terms of managing these comorbidities, perhaps if you're a parent of a patient with narcolepsy, I always encourage parents to make sure that they know what pubertal development is going on with their children. If there is early pubertal development, meaning that it's before age 10, that's something that you might want to see an endocrinologist about, because the concern is that if patients go through precocious puberty too early, their growth plates of their bones fuse, and that could curtail their absolute height. So in some of my patients, I've sent them to endocrinology to suppress pubertal development to allow more natural growth. I also encourage parents to make sure that they have the growth curves of their children, as well as make sure that they know the vital signs when they go to primary care offices or other medical health clinics, because it is something important to track blood pressure. There are freely available scales online, as well as in pediatrician and standard offices, that can assess for attention deficit or hyperactivity disorder. And there are easy to use tools offered in clinical settings to screen for depression and anxiety. So if you have concerns, certainly bring these up to your providers. At our center, I wish I could say we had a true multidisciplinary clinic, but really it's a network of referrals that I've developed over time for patients and educated specific providers about narcolepsy, which I think is a similar model to what people have done at other centers. And so endocrinology, psychiatry, GI, cardiology, neurology, these might be helpful people to have some contacts with. And then when you're thinking about treating patients with medications, we always do try to use medications that cover as many symptoms as possible. So for instance, stimulants might be helpful for daytime sleepiness, as well as attention deficit disorder. And on the other hand, you might want to minimize use of traditional stimulants if there's a concern of a mood disorder or elevated blood pressure, because those could potentially exacerbate the situation. So in terms of transitioning to a childhood to adult care, I think it's important to know what the literature might show in terms of changes in narcolepsy longitudinally across time. And unfortunately, we don't actually have a lot of information about this. There have been a few studies looking at narcolepsy across the ages, mostly in Asian countries, and this is because stimulant prescriptions require sleep studies to be repeated over time, and that might allow for sort of some comparison at different ages. So in a Korean retrospective longitudinal study of 33 adults with narcolepsy who had multiple sleep latency tests at scheduled times over a period of 5 to 7 years, they found that the narcolepsy type 1 patients, again, the narcolepsy with cataplexy patients, had fairly consistent symptoms over time, What they did find is in terms of the sleep over time, there was a reduction of deeper sleep stages. We call that N2 or N3. And the wake periods that occurred during the night started to appear longer. And there was there was more N1 sleep, which is less refreshing sleep. And over time, there was a higher reporting of the apnea-hypopnea index, suggestive of development of obstructive sleep apnea over time. And that also might correlate with an increase in weight, as they did show that over time, the BMI, the body mass index, did increase over the age. In terms of narcolepsy type 2 patients, we actually have even less data than that. Over a 5.5 year period, the narcolepsy 2 patients did show more stable nighttime sleep. And they did also show pretty stable mean sleep latency results, suggesting objective daytime sleepiness didn't really fluctuate a lot over that time period. But they did show a decrease in the number of sleep onset REM periods, which is what we use for the diagnostic testing of narcolepsy. Of those patients, actually, there were 6 patients that they reported, I'm sorry, 3 patients they reported who started off having a diagnosis of narcolepsy type 2 and then converted to 1, as cataplexy can develop years after and might change the diagnosis. In terms of comparison of patients with narcolepsy in the pediatric population versus adult, the symptoms that are more frequent in the pediatric population that were reported in one study included sleepwalking, sleep talking, feelings of sleep drunkenness, meaning difficulties waking in the morning and then feeling alert enough to kind of get going. But sleep drunkenness is sort of an extreme version of that. There was more reporting in the pediatric population of nighttime eating behaviors, attention deficit disorder, and there was actually an increased reporting of poor sleep quality in the pediatric population. In the adults, they tended to report more hypnagogic hallucinations, sleep paralysis, overall poor quality of life, and more development of sleep apnea than the pediatric population. So overall, I think it doesn't seem like much changes in terms of the functional sleep problems at night. Maybe they get a little worse in the narcolepsy type 1 population, but daytime sleepiness seems to be stably present for both narcolepsy type 1 and 2, but plausibly in narcolepsy type 2, the sleep onset REM periods might decrease. So just taking a moment to focus on our adolescent population, I think this is an understudied group in narcolepsy, yet they need probably the most support as I'm experiencing it in clinic. So just to take an overview of what happens in adolescence. So we obviously focus on the physical changes. There's growth spurts, there's maturation of sexual organs, otherwise known as puberty. And that's been much of the focus. But from a brain standpoint, there's a lot of changes that occur during adolescence. I'll highlight here some of those changes, and this is basically scans that have been taken longitudinally looking at the amount of gray matter development. So in a 5-year-old brain, basically this is a map that's showing you the most development, which is in purple, and then red and the brighter colors represent less development. So at a 5-year-old brain, the most development of the brain is in the occipital areas of the brain and the motor centers of the brain. So vision and motor movements are well developed, but other parts of the brain, including executive functioning, which is in the frontal lobes or prefrontal lobes, is really underdeveloped. And this improves during childhood. And so you can see that more of the brain is becoming more purple or more gray matter and interconnected. And by adolescence, the brain looks very similar, actually, in many ways to an adult brain, which is at the end here, except the frontal lobes are still underdeveloped. So this frontal lobes is really your executive functioning, your rational decision making. And so people believe that some of this might be that in adolescence, there is more complex and sophisticated thinking. And as a result, patients are oftentimes able to start thinking about future-oriented concerns. They're able to adapt to challenges, but behaviorally, sometimes because of that underdeveloped of the prefrontal cortex, they can make lapses in judgment or have increased risk-taking behaviors and more moodiness, which any parent probably can tell you. And then in terms of psychosocial development, adolescence is a period of identity formation. So this is defined by the roles they play in life, their relationships with others, their development of self-confidence, and their building of independence away from their family. And all of this occurs, unfortunately, during a time when narcolepsy might be developing. So I think our adolescent patients are faced with a number of challenges that might impact their normal development into adulthood. First of all, we just have to remember that precocious puberty does affect a large population, up to 30%. I think I even said more in the other slide. But all of these changes might be occurring at even a younger age where the brain might be unprepared on how to manage that. And I think that's, again, something that we'll talk about, but psychosocial supports and psychology can be really important fields to help our patient population. But overall, the fatigue and sleepiness of narcolepsy certainly can make learning challenging, impair patients' self-confidence as students and academic success, and that certainly can affect their overall self-identity. Many patients with narcolepsy experience social difficulties, and there have been a couple of survey studies expressing that. So in one study, 45% of children 7 to 16 years of age reported having social impairments. In another study, 60% of patients, their parents had reported that the patients had social awkwardness or isolation, and this was a medium or big problem. We know that sexual relationships are very important in adolescence, and use of SSRI, SNRI medications can affect the ability to have orgasm. Cataplexy can affect orgasm. And we also know that medications that can affect the efficacy of hormonal contraceptives, such as modafinil, armodafinil, and pitolisant, need to be considered even at this younger population. And of course, driving is such an important part of autonomy, really, and it really impacts adolescents' ability to form social relationships, attend events that they want to, and potentially even romantic relationships such as dating. So what can we do to support teens with narcolepsy? And here I'll just highlight my colleague's work that was just recently published, Eric Zhao, who did a qualitative research study that looked at issues that were most concerning to teens and their parents relating to narcolepsy, and had some specific suggestions. He basically identified that the validation of these feelings and concerns is something that we should be doing better in a healthcare setting. So maybe not all the time do we have a perfect answer for how to help, but to recognize that, you know, patients have these concerns in itself is helpful. And allowing them the opportunity to sort of vent or express that frustration, I think, is important. We need to recognize when they might be avoiding situations because of narcolepsy symptoms, and what that might do to their psychosocial development and identity. So avoiding activities or emotions due to cataplexy, I would argue, would not be something we would want patients to be telling us. And even though they might not think cataplexy is severe, it might have a potentially severe impact on their development. The timings of medications, I was talking to a different group this morning, but we sort of focus as physicians maybe on the 8 to 5 day in terms of medications, but we know that kids and teens have so much going on after school. So we really do have to be thoughtful about extending medication use into those early evening periods to help them. Monitoring for signs of depression, anxiety, and substance abuse is obviously very important, especially because of the types of medications we use. and then providing opportunities for teens to have important discussions with us. So as much as possible, and I'll go into this in a little bit more about transitions, being able to have some protected time with just the patient and the provider, with the parent or caregiver out of the room is really important. And this might need to be requested ahead of time. Other things we can do, and I think Wake Up Narcolepsy and the other advocacy groups all have respective support groups, but I think this is really important for teens and children to kind of connect with others who are going through the same types of struggles and learn from one another about, little helpful tips and tricks. I think, those life hacks can be really helpful. I've often found in our own support groups that having young adults, people who've kind of made it through that difficult journey, come back and talk to people about what they're doing and how they got there can be really helpful. And as Wake Up Narcolepsy does, educating the community, offering counseling to nursing, teachers, and other groups about narcolepsy can help the overall support of these patients. And then, as I mentioned earlier, sort of developing networks of ancillary support services, such as psychologists or other healthcare providers who know about narcolepsy, can be really helpful for that support. I just want to put in a plug for a research study that we're doing to try to develop better outcome tools for narcolepsy. It's called Patient-Reported Outcomes for Pediatric Narcolepsy. And participation requires taking a few surveys. As a thank you, we do offer a $50 gift card, but we're really trying to develop a survey that could be used clinically that identifies more than just sleepiness and cataplexy, so that providers or healthcare providers can appropriately treat or address important issues to the patient. And then another plug, I mentioned Dr. Eric Zhou's work. He's sort of putting together all of this information that he's learned from the qualitative research I mentioned into a website that's really aimed primarily at adolescents and young adults with narcolepsy. And so I will put the website in the link. I think it's here, but he will be announcing research to get some feedback from patients as well to further improve the site. All right, so in terms of transitions to adult care, I think, this really is going to vary depending on your clinical practice. There are some centers that require the transition to be at age 18, and there's no exception. Whereas there's others, for instance, my hospital, which, if you have an existing condition that you've been seen for before the age of 18, we're allowed to continue to provide care up to 25. And then there might be other areas where it's insurance-based. So you do need to kind of find that out. But it is an important topic because there is a vulnerability to this transition. As we sort of have already talked about, adolescents and young adults might not have developed skills to make appropriate decisions in terms of their health care. And in the adult setting, all of that decision-making is placed on the patient. So, if they don't know how to contact people for medications or urgent issues, that could result in medical complications. If they don't know how to make a follow-up appointment, that could result in a discontinuity of care. If they don't know about how to ask about the efficacy of medication or potential side effects, or advocate for themselves when there's a problem, that might limit their overall health and well-being. And because, patients in this population tend to have, as I said, sort of underdeveloped executive functioning areas of the brain, they might be more likely to take part in risky behaviors, and that in itself could result in ER visits and hospitalization. There was one survey that was a parent survey that basically asked how well parents felt prepared to make the transition, and 83% reported that they felt unprepared to make a transition to adult care with their current adolescents. So in terms of offering a roadmap, there are resources. I think it's literally called Got Transitions is the website that offers sort of a stepwise plan by age, and that's what I outline here. So between the 12 and 16-year-old patient, it's advised that patients start spending more time alone with their provider without the parent in the room. And I know how this goes if you're a parent. Sometimes the adolescent doesn't tell us all the information that you were hoping that they would convey, and it doesn't feel like a meaningful visit if we spend too much time with the patient alone. But having some time alone, I think, is important. And here I would advise parent and caregivers to email concerns to the provider before the visit so that we can make sure we address everything timely. It's also important that the patients should understand what their healthcare needs are, what to do in an emergency at this age. They should have an understanding of how often their medications need new prescriptions, how to get refills. So literally entering it into their phone number or into their phones with the appropriate phone numbers with the appropriate prompts, I think, is something that could be done. And they should understand the side effects of the medications they're on so they could report those if those were to occur. And they should also know how to reach the office in the case that something happened. They lost their medication, know how to contact nursing or their physician. Again, this could be in their phone if they have one. Between the ages of 16 to 18 years, it's emphasized that patients should be able to summarize their own medical information. So when were they diagnosed? How were they diagnosed? What medications were tried? What resulted in side effects? What are their allergies? That kind of information. Also, by the time they're 18, you're getting to a point where they might be the person, they are the person who are only have access to medical records, and the parent no longer is unless a decision is made for shared decision making, but that's something the patient themselves has to opt into. That actually might also be age dependent and site dependent. I've seen this rule applied for 16 and above. And you should, as we talked about before, they should understand the clinic transition policy. There's not that many sleep providers, and there's even fewer that are experts in narcolepsy. So these wait times can oftentimes be 6 months or even longer. So making sure that, you have that lined up maybe well before the 18th birthday or whenever the point of transition is going to be really important. And, having that information about who the transition is going to and being able to recover any important decisions that were made regarding medications that are in a clinic note, as well as the diagnostic studies that established your diagnosis of narcolepsy is really important, because that's a one-time document. And you might need it for prior authorizations or other medications or participation in clinical trials down the road. And then once patients reach 18 or the transition age, I think that's when, if they want their parent or guardian involved in their care, so if they can call for information or advocate for the patient, that needs to be documented formally in the chart as someone who has access to their medical records. For us, it's a proxy system. And, if there was any procedures or anything like that, like a repeat sleep study, the parent no longer needs to come with them for that type of testing, so they can potentially do that more independently. Upon transfer to the adult care system, I think it's really important to make sure you have a concise medical summary from your pediatric specialist. And for this, I oftentimes recommend that you have sort of a terminal visit with your pediatric specialist that is well documented in terms of diagnostic studies, labs that have been done, medication history, adverse reactions, current medications, any assessment scales that can, like the Epworth Sleepiness Scale, that can be used longitudinally, comorbidities, and healthcare goals. No provider wants the 1,000-page book of all the records that have come from a certain hospital. It really needs to be something concise. And as I mentioned before, prior authorizations are getting harder and harder. So if you do not have information about why a medication was stopped or why it wasn't efficacious and when, and you don't have your diagnostic testing, you might not be able to get the therapy you desire. Understanding the limitations of your own healthcare plan is certainly important. And then having a good understanding of how your new provider wants to be communicated with. It might be a online portal system, it might be phone call, and how you make appointments and can access future appointments is really important. All right, so just in my last few minutes, I just wanted to highlight management across the ages from a behavioral standpoint. So in terms of behavioral management in the pediatric population, naps are really critically important. These are, of course, important both in adolescents and adults, but truthfully, the time might be less for integrating naps into the workday or school day. But children oftentimes have some rest periods that we try to build in somewhere in the morning, usually around 10 o'clock, and then again after lunch, and then possibly again up after school. And the nap should be brief, 10 to 30 minutes. Of course, children and adolescents, as well as adults, need to make sure they're getting an appropriate amount of sleep. But for children, that sleep duration is much longer. So it could be up to 10 hours and needs to be protected as such. It's important to maintain activity. So sometimes I see that these nap periods come over gym or their physical education, such as recess. And that's a mistake because, as I mentioned, obesity is so common in this group. We do want them physically active, and actually activity helps boost some wake promoting chemistry that can be helpful to get them through the day. Avoiding heavy meals such as heavy carbohydrates. This is also the age that I think organizational reminders can be helpful, alarms or phone reminders if they have a phone. And we do have some resources for psychosocial support, such as cognitive behavior therapy for hypersomnia to help with coping, management of stigma, which can help them as they grow. In terms of school accommodations, in addition to naps, I sometimes find movement breaks, fidget spinners, or fidget devices can be helpful for maintenance of alertness. The ability to record classes or access notes can be helpful. Having extra time for presentations, projects, and homework, and then making sure that they have some capability of extra time for tests or stop the clock breaks if they want to move around during testing. So I think that sort of takes us to college, where in addition, having the ability for early registration so they can get the courses that they want at the right times. So if people like to sleep in and that's an important part of their treatment, they might want to pick afternoon courses, or if they feel their afternoons are really difficult because medications wear off, they might want to select morning courses. I tend to recommend that people try to take course sessions that aren't too long. So sometimes, for instance, science courses are a lecture followed by a 2-hour lab. If there's any ability to break that up into lecture at a separate time from lab, that might be more beneficial for our patients. And then dorm requests. This is highly personable. So I would just say that each person might be different in terms of what they actually want. Some people want a roommate, and some people feel very vulnerable on medications they're on. But in any case, I recommend having a lockbox for medications such as the oxybates and stimulants, as those could be used for nefarious purposes or sold. And then there also is the need for maybe an RA to be close by, so that if the patient was sleeping and couldn't wake up, maybe they're on an oxybate, that someone knows about them and can assist them out of a building, say in the setting of a fire or other alarm setting. And then others oftentimes will request classes, or sorry, their dorms close to classes so that they can come back and take a nap midday. Workplace accommodations are variable, but there is the American Disabilities Act that requires most employers to provide reasonable accommodations to perform work obligations. This might require that a patient report their narcolepsy to their employer, and that in itself is a personal choice. But timing of medications, again, is important. There might be the need to ability to integrate naps. And then, again, making sure that people are getting enough sleep, and that they try to prioritize, work that might require more attention and be more monotonous, maybe in the morning when medications might be most active, and the less exciting tasks later in the day. Other things are like walk breaks, stand desks, and keeping a cool office can be helpful. And there's some important resources here at the Healthy Sleep Med .Harvard website for workplace accommodations. So in conclusion, it's certainly important to start early in pediatric care, to start promoting these ideas of independence and knowledge of disease management. And that's really in order to prepare patients for their adolescence as well as transition to adulthood. I think recognizing that our adolescent population really has some unique challenges, and this is an important area to provide more support. That there are phased efforts that could be implemented in terms of the transition to adulthood that need to have everybody on board, not just the patient, but also the family as well as the provider. And there's certainly helpful resources helpful to patients as well as their parents and caregivers offered through all the advocacy websites. So I encourage people to go to them to continue to offer support for themselves as well as their children. gottransitions.org is the resource I mentioned for the phased stepwise plan for making a transition that can be helpful to refer to. And thank you.
Great. Thank you, Dr. Maski. Wonderful, wonderful information and presentation. We do have some questions. Somebody's asking, this might be too technical, but on comorbidities, Dr. Ruff said that there's a big overlap in dysautonomia and idiopathic hypersomnia. Have you seen anything on this, maybe POTS related in the pediatric population?
Yeah, that's a great question. And yes, I do think that there is some reporting of autonomic problems, dysautonomia in the narcolepsy population. That's a very broad category of conditions. So POTS being one of the more extreme. What's more commonly reported in narcolepsy is orthostatic hypotension, meaning that when people stand up, they might feel lightheaded, and sometimes this can get exaggerated, and there's a prominent tachycardia response, and that's POTS. So there is sort of a spectrum of autonomic problems in narcolepsy, and I don't know of any comparisons in terms of idiopathic hypersomnia to say which one's worse.
Okay, thank you. And just before I go on to the next one, if you could put the link for Dr. Zhao's resource in the chat, that would be great.
Yeah.
Make sure you.
Yeah. To get that out. I'll make sure I do that before I sign
Okay,
up.
that's fine. And then in terms of diagnosis delay, how often are patients misdiagnosed with IH instead of narcolepsy type 2? Are there any treatment implications of this delay?
Yeah, I think that the finding that cataplexy was something that's contributes to that diagnostic delay suggests that narcolepsy type 2 really bears the burden of delays, maybe more than type 1. And idiopathic hypersomnia is such a more recently described condition that people might even have less awareness of it than narcolepsy. So while that grouping wasn't specifically addressed in the survey, I imagine that diagnostic delays would be even greater in those two groups.
Okay, thank you. Any tips for asking kids about hallucinations? For a long time, I just thought they were bad dreams and wouldn't have mentioned it to a doctor or parent. Yeah,
and I think it's difficult because nightmares, very vivid dreams are also very common to patients with narcolepsy. But hypnagogic and hypnopompic hallucinations are really focused on symptoms that are occurring as people are falling asleep or waking up. And yes, that can happen if they woke up in the middle of the night, but it's usually a specific image, like a scary figure in the room. Younger kids might report shapes or an animal in the room, but it's sort of like a formed image, not necessarily like a more narrative type of thing that we would associate with dreams.
Okay, thank you. Narcolepsy is a new diagnosis for our teen. If they get into a good sleep hygiene routine, does that decrease the need for recovery days? We are trying to learn what his limits are.
Yeah, I mean, I think that it's important that teenagers get the minimum of 8 hours of sleep every day. The consistency of the timings of sleep is also important. And that's where I sort of lose my adolescents sometimes. But, as much as possible, making sure that the timings of their sleep, weekends and weekdays, are fairly consistent. So, that means if they have to wake up by 7 on weekdays, then I really encourage them not to make it any longer than wake up time of, say, 9 a.m., 2 hours later on weekends. I have colleagues who are much more strict than that, but I think that's just sort of where if it's too shifted, it becomes really difficult for patients to wake up, say, Monday morning. And that in itself sort of starts the week wrong. And it, oftentimes they're more sleepy, and then you add medications and they can't sleep. So I think that question really highlights on an important opportunity to kind of make sure from a behavior standpoint that everything's in place.
Good, thank you. Are diagnostic tests regularly redone during the transition from pediatric to adult care? And when would that retesting be required?
Technically, you should not need to repeat the testing unless there was some concern from the new provider. And I am encountering that issue. So sometimes diagnoses such as narcolepsy type 2 might be in question because the person did not sleep a sufficient amount of time, or they were on medications at the time that might have altered their test results. So it is up to the adult provider to decide whether they feel like it's necessary or not, because they're going to be the new person prescribing the medications. So I've seen it repeated in that situation. The other situation would be if there's concerns of obstructive sleep apnea. So the provider might want to maximize treatment for anything that's treatable, essentially, to help the patient. And in that situation, a repeat sleep study might be done for, again, a different sleep disorder that might be comorbid with narcolepsy. The third reason is that participation in some clinical trials requires a sleep study to have been done within a 10-year period. And so as the treatments are getting better and there might be more clinical trial development, a provider might recommend a repeat testing.
Okay. Excellent. Thank you. Appreciate the attention to naps. Could you share how the 20 to 30-minute recommendation was reached? Love the behavioral approaches, so much applied to adults too.
Yeah, no, thank you. So the naps really are from data that was collected way back in like the 80s and 90s. So it was sort of found that briefer naps, where patients with narcolepsy specifically go quickly into REM sleep. So that's usually within a 15-minute period. And once they went into REM sleep, they sort of were able to dissipate that REM sleep, and that seemed to help with the management of reducing sort of transiently their daytime sleepiness. But the stage right after REM sleep is deep sleep. And that's a stage where once you get into it, it makes it very difficult to get out of it. So that's why we try to limit it to that short nap, because it seems to be more refreshing. People are able to wake up more easily and, again, still function thereafter. Whereas if you go into deep sleep, more difficult to wake up, more difficult to function, because there might be that more profound sleep inertia and people feel like something was taken from them, that they had to wake up from that stage.
Thank you. How do you handle the point in life when, adolescents who have narcolepsy want to get their driver's license?
I think people do it differently. So there is no standard way provider to provider. In my practice, we originally started with doing a test called a maintenance of wakeful test, which is an objective test of alertness on the medications the patients were on. But it really held no functional value, meaning I had patients who passed that who still got in a car accident. Or I had patients who, I remember one patient who was like, had a rubber band on their wrist and they were like snapping it the whole time, trying to stay awake to pass this test. And so it felt like a little bit of an arbitrary situation, and it is pretty burdensome to do that test. So I just have a candid conversation with patients. If they have, I give them the Epworth sleepiness score, I give them other surveys, and I have open-ended questions with them about their degree of sleepiness on their current treatment. And if it's more than mild, I will say, well, let's try to optimize the medication management a little further before we start driving. But if it's mild or well treated, that's a grouping I feel comfortable with. And even in that group, I think it's a conversation about the realities of driving, which is that there's a 4 to 10 time increased risk of having an accident with narcolepsy. So short drives, in-town driving usually is a good place to start and build from that to longer drives. And I think highway driving is always going to be a risk for people who are sleepy, but it is something that they could potentially build to.
Thank you. The next question is about guided meditation. Yoga Nidra is known to offer sleep restoration without actually going into sleep through a guided meditation. Has this been explored as an alternative to a nap?
It's a great question. I think the only study I know is the Ascent study that was done through Northwestern. I think originally it was Jason Ong who had done that study, and as far as I know, it's in a feasibility trial, and I'm not sure they're recruiting more patients. But the idea was, to have some kind of, I don't know if it was guided meditation per se, but some type of intervention that allowed people to have this sort of structured cognitive behavior therapy that did allow for some meditation within that. And I think it's a great idea. I mean, I think it's not been studied, but I'm very interested in non-pharmacologic treatments that we can offer our patients. So it really is something that should be done.
Great, thank you. Any last questions for Dr. Maski while we have her?
I'm just going to look quickly for that website.
Okay.
Oh, he says it's in the slide. Let me just go back to that. Monica, I think what I'll do is I'll send it to you, and if you
That's
could
fine.
Share that.
We'll send that out, and we'll send the recording with it, and also the study that you're doing too. We'll put that in the email too. Wait a minute, one more question coming through. Not a question, just very grateful for all the information and resources. Thank you, Dr. Maski. In my research, I was under the understanding that narcolepsy interrupts not only sleep, but metabolism. Is this so? We'll do the final question.
Yeah, no, it's a great question. I don't know, actually. I think we don't know what disrupted nighttime sleep does to people's metabolism at nighttime. But it's all I can say is we're studying disrupted nighttime sleep, and it's really such a unique kind of sleep architecture, because unlike insomnia, patients with narcolepsy are able to return back to sleep so quickly. So the wakings are very, very brief when they do occur, and the transitions are rapid. So we just don't know.
Time for one more?
Yeah, sure.
Okay. How can my child better communicate to her peers about her narcolepsy?
Yeah, I think that's a really critical question. I don't have a specific answer other than I think Julie Flygar has a program through Project Sleep that is based on development of self-advocacy and includes this particular topic of how children can communicate with their peers. But when patients ask me, I tell them, you basically have to communicate it as you have a neurologic condition. This is not in your hands. It's not something like you're lazy or bored and you have narcolepsy. And if they ask further questions about it, you can tell them that you have uncontrolled sleepiness and medications work, but not all the time. And I think, how much more further to go into it is their decision. But I think that communicates it quickly that there is a problem. It's not their fault. That, that if they're sleepy, don't take it as I'm disinterested or don't care. But I think that Dr. Zhao's work has highlighted a lot of the nuances between pediatric patients and their relationships socially. And that was a big concern that, they constantly had to be making choices about what friend was worth, their wake time, what activities, should be prioritized. And then there was a lot of guilt when they had to cancel events or they couldn't show up or have full participation. And I think, that kids need to have the ability to forgive themselves for those kind of things.
Good. Excellent. Thank you. Thank you very much. It was wonderful as usual. So nice to see you, Dr. Maski. And I just want to thank our sponsors, Avadel Pharmaceuticals, Centessa Pharmaceuticals, Takeda Pharmaceuticals, Harmony Biosciences, and Jazz Pharmaceuticals for enabling us to bring this information to the public. So appreciate your time. Thank you very much. And thank you everyone for attending.